Thank you for giving me this opportunity to share my thoughts, and my thoughts are being lined and discussion with several stalwarts like Dr. Amit Jala, Dr. Ajay Krishnan, and our current ASSI president as well, and few of my fellows who has given input too. I'll start with the two talks, the morning talks. Some of you may have not attended, and they were from Dr. Abhay Nene and Dr. Rajesh Parasnis. Quite inspiring talk. And would like to start with a joke. You know, we were all sitting at the end of the ASSI meeting, and quite a few senior presidents were there as well. And the question was asked by one of the most junior guy, you know, what would be your best day? And, you know, one consultant said, when I read the book. One president said, you know, when I have the music. Abhay said, you know, when I go to the mountain. So I was just thinking, you know, what am I going to answer? And I said, the best day would be the day when I put a screw into the operation theater, because that is something which I am assigned to. And I'm sure, you know, everybody sitting here would feel the same as well. So with that background, you know, I would just give my talk on how ASSI can help building the MISS in India. My words and presentation is purely on the topic allotted, not to hurt anybody. So please do not take it to, you know, I'm not here to hurt anybody. The talk when I was preparing, you know, it looked like going to Jungfrau or sort of, you know, building up and planning the Jungfrau. I started thinking, you know, how am I going to do? And so that's why I took the help of the colleagues. So what is the misdefinition? I'm sure everyone knows this. Small incision, less exposure, less infection rate, low blood loss, and then quicker recovery. And one addition was probably less destruction or rather no destruction. And, you know, reconstructive surgery can be done with the MISS. But let's define MISS surgeon. I'm prepared here to propagate the MISS concept. That's why I'm here. But the concept is a bit different among us as well. So there are few who are only MISS surgeon. There are few who are pseudo MISS surgeon. They want to get converted into this, and that's why, you know, these meetings would certainly help. And this organization has certainly created quite a few MISS surgeon as well. And there are few who want to pursue this as a MISS surgeon too. So I have sort of started that let's have the hypothesis that everyone favors in this group, in this hall, they favor MISS, and otherwise this talk wouldn't have any meaning. So there is a lot of lack, you know, consensus, because we just saw, you know, those previous two cases presented here. One will do this, one will do that. At the end of the day, you know, we should have the adequate decompression. So that's a concept. But there are centers who does 50-50. There are centers who does 30-70, or even vice versa, MISS versus open surgery. But the caveat here, most of us, we believe that all our cases are high-end cases, and hence MISS may not be feasible. So coming to that, you know, the MISS, why it was formed, I think when me and Amit Bhai, we sort of, you know, thought of having in ASSI one group, you know, where we can have one session. And 2014, that's the first MISS meeting was conducted at Ahmedabad. You know, we met, and then Amit Bhai said, you know, because then we should have one session in ASSI, but then it was not granted at that time. And we thought that we should have the MISS or other MISSAB, and it converted to Bharat. So MISS has been formed. There are vision, mission, excellent website being done as well. And I think that's been done by Dr. Ajay Krishnan too. So milestones has been laid down. MISSAB is now a fully grown body, a fully grown society. It's now adult, you know. So let me just evaluate few centers of all over India. Our center has 5+5, and MISS is done by 4 spine surgeons out of 5 group, our group. I'm not the one who does the minimal invasive surgery because of the time constraint, and probably, you know, now approaching 60, so, you know, we do not want to get into that. High volume centers, MIS is not done as a routine because probably it is time consuming and the learning curve is high as well. Teaching institute, MIS is not done as a routine as well. The reason being training, time, concept, and probably cost as well. So this is something where, you know, one can really think of why are we not having more MIS surgeon? And there are MIS centers only doing MIS, whatever pathology it may be, whatever compression it may be. And, you know, they put the screw, even they have started doing the costiotomies as well. And they are the corporate places. There are few places where I do not want to name them, but there are one, you know, they have the mindset one has to have that MISS. And there is one center who has changed from MISS to open. And why? Because he probably has now started assigning his work to the juniors. So he cannot rely on them. And so that is why that center got converted from MISS to open as well. So this is the kind of scenario which we have in our country. There are 300 trained spine surgeons in 8 years by one of the company. MISSAB has trained about 150, only 30% have adapted. Why not 80%? Probably that's not something which I'm going to discuss, but I have already narrated a few. In the last 1 year, there are about 30 conferences in India, but about 5 have been conducted singularly, and the faculty has been the same as well, running from one place to other place. So should it be that way? I'm open to discussion about this, but I think let's have some sort of group, and that is why we need to really have the MISS group formed as well. So we should plan to work together, MISS and ASSI, because we need to work together, exclusive but not exclusive but inclusive. We need to learn together, we need to train our colleagues, our juniors together, we need to progress. Co-branding, revenue sharing has to go hand in hand with the ASSI and MISSAB. It has flourished as a separate organism, but should continue, but then should have been sort of with the ASSI as well. That will give a good stepping stone to MISSAB as well. There is a cause for it to get better, and there are combined effort has to be put in. I think we should have something like AO-Spine educational body. With the two groups coming together, we should be able to form one, and that should concentrate only on the research, and we should have a curriculum of MISS too, or even ASSI as well. We have had 2 fellows, and we have the curriculum of ASSI. Similarly, MISS should have the curriculum. We have started having, the fellowship as well. The center, our center has got the fellows coming every now and again. So we should have a curriculum for them. Certificate to be issued, maybe about 50% if they are doing it, we can issue the certificate as well, or MISS can take the further step. But can we have the extreme step like this? In the GBM, let's have, raise up hand how many are doing 50%. And let's push them, to do more and more. That will really help, because that's a concept, has to go hand in hand as well. Show the data, and let's have the honest acceptance that, yes, my center is doing 50% of it. White paper statement, like, we have had the stem cell as a white paper in the ASSI website. Similarly, MISS can be put in as well, that this is something which is a newer way or the better way of operating as well. Industry has to bring faculty and in order to educate people. Merger of the two society, as spoken earlier, it should be inclusive, but it should not be exclusive. Merger of MISS surgeon, this is very important, because that will bring the technology together, and that is what will really give all the spine surgeon, MISS surgeon, the best of the best technology wise. Ego, I think ASSI has got the least ego in the FIS bearers. I would accept that. I would really honor that. I have attended all the GBMs. I have not attended MISS GBM, but that is something which I would say that, that is something should exist in everybody. We as an ego have it in our operation theater, but not when we are in a common forum as well. Motivation from the senior has to go on. Registry to maintain, like ASSI has a registry, or we can have the MISS registry into the ASSI registry too, which I am running. I'm in charge of that. Incentive, trained spine surgeon not performing, mentor relationship should be continued. That is where, why did you not do it like that? That will certainly help push the junior guy to carry on. This is something, the statement from one of my fellow, MISS should have live surgeries, cadaveric endoscopic spine workshop. That was something coined by one of the surgeons. Common platform, common application, like, doctor, the case presentation has to go in. Digital surgery and AI surgery is the future. Industry involvement, probably you cannot really avoid it. Develop Make in India with the multinational company. That is something which I'm sure will be propagated by the government too. And data should be, analytics should be used to perform what kind of complication which we have. That will certainly give another push to somebody who want to do the MISS surgery with good standardization and probably protocol based as well. Because it is very difficult to set the protocol, but at least, we can have 1 or 2 options ready, for X surgery, for X pathology. And labs should be propagated. Structure like AO spine should be carried on. The higher position, they don't, once you reach a higher position, then, you have somebody who will chip in after 2 years. Not like, we have the continued same person holding the same post as well. Discussion forum has to be set. Multi-center studies should be, done by the MISSAB leaders as well. employ extra brains. Like, I'm struggling to have the registry maintained as well. So if we have sort of people who are working for the MISSAB, then, we'll have the registry developed as well. And everybody should have introspection and should come forward with the cases which has gone wrong, like adjacent level, facet injury, something like that. That will be a great learning process too. And probably decentralized team, like we have the decentralized surgical team, where one will do the MISS, one will do the endoscopy. That kind of thing would certainly have with the MISS incorporated, and will certainly reduce the inventory. With the increase in inventory, too contradictory, because if you have good inventory, but then MISS surgeon working together, we certainly have the good inventory maintained as well. So MISSAB is an offshoot of ASSI. Most of the members of ASSI are active members of MISSAB as well. So it should complement the activities of ASSI. As discussed in EC, this is from Dr. Shankar Acharya, MISSAB could have its annual function with ASSI once in 2 years, replacing ICS, or 1 year can have its own. And also, MISSAB can conduct some outreach sessions with ASSI. ISJ, Spine Journal, should have the supplement of the MISSAB once in a year, and we can talk to Dr. Anil Jain as well. If the MISSAB is interested, that's what, anybody would say that. But I'm sure, we are planning to have some kind of understanding with each other. Coming to the severe experience, we have introspection. What we have learned over this year is demand and supply. We have always thought about be different. We have always thought about when the demand has increased from the patient perspective, patient's demand. Why can't I not have the MISS surgery? Why can't I not have the endoscopy surgery? And I'm sure, Dr. Ajay Krishnan is doing central cauda equina decompression surgery with just endoscope. And I tell you, no exaggeration, good outcome. Any cauda equina, one would say no open surgery, but we have been doing that since last few years as well, and he has published paper with the calcified disc as well. So MISS versus open surgery, the ratio should increase. Training of the surgeon should really go ahead. Tech advances to adopt. Joint effort, individual effort. I think individual effort should convert into joint effort. And I think 1 + 1 should become 3 rather than 2. That should really give us the good outcome. OLIF experience recently. I'll just take 2 more minutes. OLIF experience recently, we have had the faculty came from abroad, and good demonstrations, such sort of MISS could be propagated by the industry alignment as well. Conflict of interest should be practically, make it to 0 and have open-minded. One should become active member in one organization. That is very, very important. One cannot have, extramarital affair. This is like an extramarital affair if you are holding the same, same post in 2 organizations. So because you cannot justify the one or the other. So my caveats for the MISS surgery, statistics will follow. There are complications which are going to happen, that will happen. Like, the flight which is going to crash, accident which is going to happen, it will happen. But adoption is very important. Learning curve at a great cost is something which we see. And everyone loves MISS. I'm talking about MISS, but at what cost? You should not have the extramarital affair. Radiation is the major concern. Like, we had this OLIF surgery done recently at our center. And you could see that, the radiation exposure with each screw is really, really quite annoying. And we do not want somebody like having this hand with the radiation, somebody who becomes, malnourished or cachextic because of the radiation exposure. And we know that SRS, 3 of the residents had the onco problem as well. So my iterations, reason for the miss is not picking up, probably training, high-end surgery, case, gadgets, implant surgeon, higher clinical approach, resources. We should have Ferrari in the OT. Let's, travel with Maruti 800 with a tubular retractor. But if at all, one can have that Ferrari in the OT too. We should have dedicated program, rotating fellowship, mentor-fellow relationship has to be maintained, and adaptation likely to increase as well. So talking about my generation, I think I'm from baby boomer, and now generation alpha is going to come as well. So technology, these societal advances are going to occur as previously narrated by our SR sir. Our differences, after all, must be celebrated and encouraged. So be different, but at the same time agree to disagree on most of the thing. Pursue new technology, create solution, work to solve world's problems. And they are not problem, they are our problem as well. Let's see what Alpha does. So I won't narrate this case, but would like to just end with IoT-SS. This is probably, something where we have the gadgets in our operation theater, and probably one is going to become Thanos as we have the gadgets, and one can really do whatever best we can, convert from reality to, convert into the reality by the gadgets. Thank you.